Hello everyone and welcome back to another video on the channel. If you're new here, welcome. This channel is dedicated to AI integration into medicine, specifically internal medicine. And as you know, I've been creating questions based on educational objectives and medical concepts tested on the ABIM boards. And I kind of go through this kind of AI versus human kind of situation where I go through create these 3 questions per episode, and I make them into a series and a playlist. And then basically these are the most high yield educational objectives that everyone should know. And as you know, AI is very difficult to work around because it's easy to use and it's accessible now to everyone, but you really need to have very proper instructions and clear instructions to be able to create questions and answers that are viable, because the consistency is an issue here. So I've been working around this for about a few months now, and I've used a lot of different kinds of AIs and tools. And so today we're going to go back to ChatGPT, and we're going to create 3 very high yield gastroenterology board questions, and then go through this certain way that I've created for the answers to be analyzed. Okay, so let's go ahead and get started. So stay with me till the end of the video. The notes are going to be all available on my Patreon channel. You can access there, and just a few bucks if you want to donate, that would be amazing. If not, that's okay. The videos are available to you, and you can watch my high speed podcast, whatever you need to do. The goal is to do this together. So the first question is: a 34-year-old man with Crohn's disease presents with a 3-month history of chronic watery diarrhea, bloating, and fecal urgency despite being on stable maintenance therapy. He underwent an ileocecal resection 6 months ago due to small bowel strictures. He denies blood in the stool. Physical exam is unremarkable, and the labs show a mild hypokalemia and low levels of fat-soluble vitamins. Stool studies are negative for infectious causes. Which of the following is the most likely cause of this patient's symptoms? As you know, the question is giving you all of the things that you would need to really nail this diagnosis, but on the boards you will only get a little bit of each. So you may only get, for example, an ileocecal resection, and they won't say that you're going to have low levels of fat soluble vitamins. But these questions are made to basically really solidify that educational objective. So they're going to give you everything related to it. So they'll tell you it's a chronic watery diarrhea, there's bloating, there's fecal urgency, they're telling you the patient has Crohn's disease, and all these findings, and they want you, and they also ruled out infectious causes. So now they're asking, what is the most likely cause of this patient's symptoms? So go ahead and pause the video right here, pick your answer, and we're going to go through each of the options together. All right. So first of all, ileal resection doesn't have to always in the concept of Crohn's disease. Any ileal disease that can cause problems with the terminal ileum, I would say, or in this area specifically, you may have low fat levels of fat soluble vitamins and kind of a bile acid kind of diarrhea. So which is very important to notice. So the answer, of course, here would be to give bile acid. This is bile acid diarrhea, right? So if they said, how do you treat it? You would give cholestyramine. But let's go through the pathophysiology. So bile acids are produced in the liver and aid in fat digestion by emulsifying the diarrheal lipids. These bile acids are reabsorbed in the terminal ileum and recirculated to the liver via intrahepatic circulation. Injury or resection of the terminal ileum, which one example would be here, leads to impaired bile acid reabsorption. So anything that disrupts this process is going to give you this presentation. So excess bile acids entering the colon leads to this secretion and motility increase, which causes the watery diarrhea. Also, you will lose the bile acids due to the impaired fat digestion. So we'll have malabsorption of fat soluble vitamins A, D, E, K. So the questions could be a presentation of any of the severe deficiencies associated with any of these or these fat soluble vitamins, and then ask you to kind of say what the cause is, or they would want you to create this association of a malabsorption syndrome related to terminal ileum issue and injury. So the key clue here is a Crohn's disease patient got the ileal resection. then they present with all of these findings. The stool is negative for infection. So lactose intolerance would definitely not be the case. SIBO, it is common after bowel surgery and is actually a very commonly tested topic on boards, but typically causes, steatorrhea. B12 deficiency is not best answer here. Bile acid diarrhea, strongly associated with terminal ileum resection. So would explain these findings. Again, they will try to give you close, answers to each other, or very similar presentations, but it picks you and requires you to pick the correct information and avoid the distractors. These AI-based questions are all focused, so there's no distractors. Short bowel syndrome, so requires extensive resection of the bowel, small bowel, causing multiple nutrient deficiencies and high volume diarrhea. This patient only had the ileocecal resection, right? So this patient does not have short bowel, right? That requires its own indications, own diagnosis and presentation. Pancreatic insufficiency would cause, again, steatorrhea, fat-soluble vitamin deficiency, but not linked to ileal resection and watery diarrhea, right? So algorithm: post-ileal resection plus chronic diarrhea. Think about the bile acid diarrhea. Treatment, next step would be cholestyramine. Also replace the fat-soluble vitamins. They make sure that they taking supplements for those. And again, these are the clues to the question and the guidelines based on the American guidelines. Bile acid sequencing, like cholestyramine for symptomatic relief, fat-soluble vitamin supplementation. It says consider testing for bile acid malabsorption, which is a scan in some countries if diagnosis is unclear. SEHCAT. You can look that up. And then the correct answer is bile acid diarrhea. All right. So if you enjoyed the video up to here, you think these are highly valuable and tested questions, and you're learning something, please drop a like, comment, subscribe. Let me know what you need changed. Let's move on to the next question. All right. So this is a 58-year-old woman. She presents with 3 months of progressive bloating, flatulence, and intermittent watery diarrhea. She also has a 5-pound weight loss despite no change in her diet. She has a known history of systemic sclerosis and Raynaud phenomenon associated with esophageal dysmotility. Her medications include omeprazole and amlodipine, and the physical exam shows a mild abdominal distension and hyperactive bowel sounds. Labs reveal a macrocytic anemia, which of the following is most likely underlying cause of her symptoms. So again, they're telling you a little more. They're telling you an extra association here with Raynaud phenomenon and esophageal dysmotility. But remember, on boards, you're expected to immediately connect systemic sclerosis with these, and they will not tell you that. So go ahead and pause the video right here. Pick your answer. We're going to go through the options together. All right. So the pathophysiology. So we got systemic sclerosis. So collagen deposition and a smooth muscle atrophy, impairing the GI tract motility, especially in the small intestine. Okay. So this reduces peristalsis, as you would expect, and cause a dilation, creating an environment where colonic bacteria can overgrow in the small bowel, which now we come to this high yield diagnosis: small intestinal bacterial overgrowth. So the consequences of that would be, one, for example, macrocytic anemia due to bacterial consumption of vitamin B12, fat malabsorption, possible, bloating, weight loss, and diarrhea, excess fermentation, flatulence will present. So again, very important to notice. And then when you go through this question, again, they're telling you all these associations with systemic sclerosis. They say exocrine pancreatic insufficiency. That would be incorrect. It can cause malabsorption, weight loss, but again, not macrocytic anemia, and also not associated with SSC. Boards love associations. You need to know and immediately connect associations. Lactose intolerance would cause, the bloating and diarrhea. Again, doesn't cause B12 and weight loss, B12 deficiency and weight loss. Small intestinal bacterial overgrowth, absolute correct answer, and high yield association with SSC. And again, if the answer choice could have been added here, would be, for example, esophageal dysmotility and then small intestinal bacterial overgrowth, and you would still have to remember this is SIBO and not really the esophageal dysmotility causing this, because this patient is presenting with issues related to macrocytic anemia and diarrhea which is more tending towards the bacterial overgrowth versus the esophageal problem, right? So you should be able to pick out these closer. And then if, for example, another question could have been, what is the next step, right? So then it could be a barium swallow there to throw you off, or it could be a way you can test the small intestinal bacterial overgrowth we're going to talk about here. So the high suspicion, again, when you have the high suspicion for possibility of SIBO, the next step is the carbohydrate breath test. So those could be also another way they could answer, they could question you, would be what the next step is, and it could be a carbohydrate breath test. And then if it was a treatment, they could give you antibiotics, versus the issue with esophageal dysmotility, where they will give you something to improve maybe a prokinetic. So then you would not want to use that, right? So you want to be able to pick out the exact associations, because you cannot guess on the boards. These are all perfectly placed educational objectives based on real cases. You cannot have on boards, they will not give you two things. It will be this issue, and you really need to pick that out. And I've seen patients with SIBO, they keep coming, or these, usually what you see this in is elderly with problems with their ileum or previous history of surgery. They keep getting this diarrhea that's been going on and worsening, and nobody is able to figure out what's wrong with them. And really what it needs is carbohydrate breath test. And so this is a completely very important diagnosis to recognize as a possibility, and be able to treat, because the treatment is actually rifaximin and other similar antibiotics that you would need to put them on, and it would be a little longer duration compared to regular antibiotics. Okay, so the high associations with SIBO, macrocytic anemia, and then risk factors, and also increased folate. They may also give you that folate is higher, and they still have macrocytic anemia. Risk factors, anatomic changes, motility disorders, PPI use. Like a lot of elderly, again, use PPIs. Remember, chronically for many, many years. There has been shown that the PPI use can increase the risk of SIBO, because the bacteria are able to live in a less, or basically go through the stomach without the acidity killing them, or at least what the hypothesis is. So it's to think about. And then flatulence, bloating, and diarrhea. And the latest American guidelines, again, protocols, is to do the carbohydrate breath test, or you can do the gold standard, which is rarely done, but really is the jejunal aspirate culture. So they would, when they do the I think endoscopy or colonoscopy, I'm not sure what the best access for the jejunum would be, but they would need to grab and aspirate from there and then culture it to see the bacteria growing. And then the treatment is rifaximin. Others would be ciprodoxy. Very hard to treat. They have 45% recurrence, and sometimes may require repeated antibiotic courses. Correct. And now, of course, don't forget to supply the vitamin B12 that they're going to be deficient on. All right. So this is the second question. I've got one more question. I hope you guys are enjoying this and learning. These are all tested board questions. So let's get through them together. All right. So this is the next one. This is a 35-year-old man. He is referred to a hepatology clinic. After laboratory studies reveal an elevated ALP, he reports occasional fatigue and pruritus, but no abdominal pain. He has a history of UC that has been well controlled for several years. MRCP shows multifocal stricturing and dilation of the intrahepatic and extrahepatic bile ducts. Which of the following is the best next step in the management? So it wants you to find the association with UC that presents with this MRCP finding, and then pick the best answer. All right, so go ahead and pause the video right here, pick your answer, and then we're going to go through the options together. All right, I hope you guys picked colonoscopy, because this is very, very important, and they always try to test these, because everyone knows this is going to be primary sclerosing cholangitis in a younger kind of male with IBD, right? So that immediate association, this is from a step 1 or step 2. Those are immediate recognition that you need to have. But the important thing on internal medicine is, now what is the next step? And really, you need to understand that PSC causes the fibrotic restriction of bile ducts, leading to cholestasis, progressive liver dysfunction, increasing for cholangiocarcinoma and colorectal cancer. Very important. So this association with cancer is more tested on boards compared to, hey, what is the diagnosis most associated. Those, they usually expect you to immediately know that. What they really want you, they'll try to get you on is the associations. Again, knowing that increased risk of cholangiocarcinoma and colorectal cancer. Very important. And the key clues, again, male, younger, maybe ulcerative colitis, LP elevation, pruritus, the beaded appearance on MRCP, and one of the options were azathioprine. Again, immunosuppressants don't alter PSC progression, so remember that. Don't get tied up on that. Try to treat the PSC with something like that. They try to put that as a kind of like a distractor option, because they may be like, oh, well, he knows a PSC is an autoimmune condition, so maybe he will take, or she will take the immunosuppressant. But you cannot miss the colonoscopy biopsy. Okay, you cannot miss. It's just you need to know this. Okay, pay very, very close attention. Okay, PSC patients have marked increase for colorectal cancer, and even when IBD is in remission. So that's another way maybe to try to distract your thought process by say, oh, the IBD is in remission, he hasn't had any episodes of ulcerative colitis. That's what they will get you. Orthodeoxycholic acid is actually not proven benefit. Maybe some symptomatic relief, but really it doesn't alter the progression or reduce the risk of cancer. So maybe in a different question, they may try to ask for next best step when there's none of the other good answers there, better answers there. Maybe that becomes relevant, but in this case you cannot. Again, this is the most important association, the cancer risk. And the observation would be wrong. Again, you have to know that, and then you need to get a colorectal cancer screening. ERCP within sphincterotomy, that is indicated in for dominant stricture causing obstruction and cholangitis. You don't, just because they have some strictures there and there's dilation, doesn't mean we need to go and treat it, right? So that would be another kind of way to get your thought process off control. So the algorithm for decision making, just remember PSC, you need a colonoscopy with biopsy because of this association. And another way they can get you is, okay, so how often do you want to get the colonoscopy? If they have IBD, doesn't matter remission or active, you need to get colonoscopy every damn year. Okay, so every damn year you're gonna get a colonoscopy on a patient with ulcerative colitis and confirmed PSC. And if there is no IBD but they have PSC, you still need to get more colonoscopies compared to usual, because you need to repeat that every 5 years instead of your usual person with no risk factor, no PSC, which would be every 10. So again, this is another way, another next step, or another way. They would put the colonoscopy and the biopsy, and they may basically put it next year, or the colonoscopy 5 years from now. You've seen those questions. They will be there. But again, we try here to make sure we know this. So when you see those questions with more distractors, you're immediately able to get rid of that fluff. And AI does a really good job of removing fluff and getting to the point. And that's why we're using it. I think it's great. You should be using it to revolutionize the way you study. So pattern recognition, PSC plus ulcerative colitis, colorectal cancer, cholangiocarcinoma. LFTs are elevated here in this case. ALK-Phos, bilirubin, IgM, p-ANCA positivity. Remember that. Imaging will have the beaded ducts. Biopsy will have the onion skin fibrosis. That's another way in the question. That may just give you the biopsy shows onion skinning, and that will be the only thing that you're going to say about the presence of the disease. And this is the American guidelines. Absolutely do that. If IBD is confirmed, annual surveillance. If no IBD every 5 years. There is no medical therapy that alters PSC progression. Nothing. So don't pick the immunosuppressant. There's nothing right now that we have. Maybe you want to be the next person who develop it, but there's no medical therapy that is proven scientifically that will reduce or alter the PSC progression. Don't take prednisone. I've seen people do that. Steroids think they're going to do magic. Liver transplant is the only definitive cure, but it basically very advanced cases, okay, and that really have nothing. And another thing I would say about the cholangiocarcinoma, there is a recommendation to also check a CA19-9. And I remember I've rotated with a very good UCLA gastroenterologist, one of the associate professors back there, and he would do this. He would absolutely get the tumor markers on these patients, especially young, with new diagnosis. They want to make sure that there's nothing else they're missing. Okay, so that's the last question, guys. I hope you enjoyed. There's a series for gastroenterology. There's a playlist series for endocrinology. Every single topic of internal medicine, there's a series. And these are all high yield questions that you will be tested on. And these are all from medical concepts on boards. Okay. There's no question about this. You need to notice in and out. I'm making this all available. I'm working on it myself and presenting. I triple analyze it using AI, and I have instructions to create these answers and the way it's there. And these instructions I've been creating for over a few months to make sure we don't miss anything that's high yield on the boards. Okay. So I hope you guys are enjoying these episodes. Don't forget to like, subscribe, notification button. Stay with me. If you stay with me till the end of the video, that'd be amazing. You can put it on a high speed and watch it 2 speed or 1.5 speed, and you'll be done in less than 10 minutes. So I hope you guys are enjoying this. I'll see you on the next one.